My name is Steve Buckner. I'm a firefighter paramedic with Tri Lakes Monument Fire Protection District. This is Jason Kelsey, who works up there also as a firefighter EMT. We're going to go through the steps, skills for rapid sequence induction of a normal adult patient. First thing you want to consider, scene safe BSI. You'll want eye protection for intubation. This will be a normal intubation. The procedure is paralyzing them to get ready for intubation. So when you walk in, you see somebody in distress, BLS airway, and you want to start considering, is this a patient that can be RSI? Indications for this would be any kind of respiratory distress, failure, altermentation, unable to protect their airway, gag reflex, trismus due to a closed head injury, and anticipated decline of any kind. So a polypharm overdose would also be a candidate for this. Contraindications, any obstruction or partial obstruction or suspicion of an obstruction, stridor, epiglottitis, malformation of any of the anatomy that you know of, tracheal oral burns, any tracheal laryngeal disruption, hard blow to that area, or any oral or facial hemorrhages would all be contraindications to paralyzing somebody. To select a patient in to make sure they're a candidate, you need to consider, can you intubate this patient? Will it be a tube that you can get at your skill level and your experience level? And then can you bag this person? Can you get a good face seal? They don't have a beard, they don't have a strange anatomy, large overbite, anything like that would make it difficult to bag this patient. Missing teeth can be something to consider also. The Lemon manometer is a good tool for considering whether a patient selects in. It's a look externally at the physical attributes that we talked about. Evaluate the 3-3-2 method is 3 under the chin, 3 fingers able to fit side by side in between their teeth, and then 2 between the hyoid and their jawbone. And if somebody meets those criteria, they should be a fairly easy intubation. Mel and Patty classes, O is for obstruction in Lemon, and then the neck motility would be a consideration also. Once I've bagged and evaluated whether this patient selects in, I'm going to have my partner start ventilating for me, and then I'm going to prepare all my equipment. We're going to get patient on the monitoring devices, pulse ox and the monitor, so we're making sure we're adequately pre-oxygenating the patient. And then we're also going to get a backup airway ready, such as a combi tube or LMA, in case we're unable to successfully intubate after we've paralyzed. Once you have all your equipment prepared, you're ventilating the patient, pre-oxygenating the patient, the drugs that we're going to use for RSI, before you push anything, you want to check 5 patient rights, and then any adverse reactions in the past to the drugs you might be pushing for this patient. Atropine is given for any heart rate less than 60 in an adult, and for all pediatric patients. Lidocaine is considered for any possible head injury, closed head injury with increased intracranial pressure. Etomidate is our sedative for this, and we're going to give 0.2 milligrams per kilogram, and you push that over a minute, and then you give it about a minute to take effect. And then succinylcholine is 2 milligrams per kilogram IV push. So once you push the drugs, you're continuing to pre-oxygenate, you're monitoring pulse ox, you have all your confirmation steps ready prior to pushing sucks, and then you'll be able to assess adequate paralyzation and sedation. You'll sometimes see fasciculations, but they will lose their gag reflex, and you'll be ready to intubate. Okay, once you've given your drug administration, you're waiting for adequate paralysis at that time, and so I usually like to go over and begin bagging for myself at this time so I can assess that. And then once you believe you have adequate paralysis, you're monitoring pulse ox, you have your CO2 monitoring devices ready, and all your confirmation steps, EDD, your stethoscope for breath sounds, and you'll go ahead and intubate the patient, and hoping that you have a pulse ox up well over 90 at the time. And so once you have your tube, verbal or visualizing it through the cords is a confirmation step. This is all the same that you learn with your intubation skills labs and stuff. A negative EDD prior to inflating the cuff is another second confirmation step, and then we will go ahead and listen to breath sounds, negative epigastric sounds, and do our CO2 monitoring for our 2 more confirmation steps. You need to have at least 3 usually to keep your tube in place when you're doing RSI. So at this point we'll secure the tube with a commercial device or a tube tie, and then I can have somebody else come and start ventilating again. Once we are very sure we have a good tube, all our confirmation steps done, we have 2 more drugs to push because that sucks will wear off and we'll need to paralyze them again, and we use vecuronium for that. And then sedation will be also needed, and fentanyl will be used for that, or Valium. And we're not worried about respiratory depression with these because we already have a good airway. Also consider putting a cervical collar on to keep that tube in place, and then reassess every time you move your patient just like you would with a normal intubation. That concludes the rapid sequence induction scenario.